Good evening, everyone. This is Shruti Bharadwaj, a proud volunteer at Project Step 1. Project Step 1's mission is to provide free access to healthcare via telemedicine to the needy Indians affected by COVID-19 pandemic. We have now signed up with 9 states: Karnataka, Madhya Pradesh, Chhattisgarh, Uttarakhand, Punjab, Maharashtra, Odisha, Nagaland, Delhi, Meghalaya, Arunachal Pradesh, and Jharkhand. And we have touch based around 3 million citizens. Today's webinar is all about setting standards for ICU care, ICU management of COVID-19 patients. On the panel, we have Dr. Matthew J. Jackson, Joint Clinical Director, Critical Care at Stepping Hill Hospital, Associate Senior Lecturer, Edge Hill University. We also have Professor Madhusudan Upadhyay, Professor of Anesthesia, KMC, Mangaluru. And also we have Dr. D.C. Mahesh, HOD Department of Anesthesiology and Pain Relief, Quality Champion and Coordinator at Rainbow Children's Hospital, Bengaluru. I welcome you all. Doctors, should ICUs become overwhelmed by COVID-19 despite such strategies? Critical care triage should prioritize patients for intensive care level. Should they understand consult facilities management to safely cohort COVID-19 patients? And some countries now have provided with the guidelines of COVID-19 ICU management. I request Professor Madhusudan to shed some light on this and also introduce the doctors in brief. Over to you, Doctor.
Thanks, Shruti. I think it's one of the most wonderful things to discuss about the critical care and COVID, because as the other panelist had just put up some time ago, Dr. Mahesh said the things are changing by the minute, by the hour, or 3 times in a day. The guidelines change, the protocols change, the SOPs change, but that is the way it is. The COVID-19 has changed the way we live, the way we change our clinical practices. Everything has changed. And I think, as Shruti has said, it's pretty difficult because ICUs are overwhelmed. The hospitals are filled up fast, especially in the metros, big cities. We have paucity of beds. I think it is time that we start triaging them before they enter the hospital and before they enter the ICU. I think it's time for us to be the leaders and decide who enters the ICU, who needs the critical care, and who needs a ventilator. And obviously, we anesthesiologists are at the forefront. And I think it's only apt that we discuss today. And we have Matthew Jackson. Dr. Matthew Jackson is Shruti has given a brief intro to him. He's Joint Clinical Director for Critical Care at Stepping Hill Hospital and Associate Senior Lecturer at Edge Hill University, where obviously Shashidhar is closely associated with. And in the past, the most fortunate thing is, in the past, he has worked during the influenza pandemic of 09-10, and more importantly, Ebola epidemic in the West Africa during the year 2014 and 15. And he also co-led the local response to COVID-19 in Stockport. Before anyone else woke up, Stockport had their SOPs in place. He has a special interest in medical education and clinical research, and he has been quite useful when it came to medical education and clinical research for the department at the Edge Hill University. And he has also been associated with the implementation and management of NEWS 2, National Early Warning Score 2. I think he has done wonderful work. And I think today we will also learn a lot from him and the other panelists about the triaging into ICU and triaging for the mechanical ventilation. Over to Matt Jackson. Over to you.
Thank you. So I'll just spend a few seconds opening up my share screen and start the presentation. So thank you for that introduction. As we enter the pandemic, standard setting doesn't seem in some ways the most interesting or exciting aspect of responding to the pandemic. When you look at definitions for standards though, what I'd like to argue throughout this presentation is actually when you're going to be faced with a massive number of patients, having to work in very, very different ways, having to work with staff who don't have the high level of training that is normally in critical care. Actually, what you really, really need is your bedrock is a good set of standards so that you can standardize your approach to this massive influx of patients. So I'm going to briefly touch on my experience of the swine flu pandemic around 2009, and then the ongoing influenza pandemic surges that we have on a yearly basis in the UK. Going to talk a little bit about my Ebola experience, and those are really just ways of sort of introducing how I came to the challenges that were presented by the COVID-19 pandemic. The process that we went through, identifying what those challenges were going to be, recognizing what we already did well, and trying to make a plan that addressed those challenges and played to the strengths that we already had in the department. So swine flu happened in 2009. I was at that point in time a junior ICU doctor. We experienced about twice the number of ventilated patients that we would normally have on intensive cares across the northwest of England. It led to a small amount of stoppage of elective surgical services in order to facilitate these extra patients. There was some understanding of the need to wear PPE, face masks and gowns and the such, but I think it's fair to say that the donning and doffing practices were quite poor. So people were going through the steps of wearing a face mask and of wearing extra protection, but actually there was probably a lot of cross-contamination between staff and patients, because the putting on that protective gear and taking off that protective gear was quite poor. I think swine flu in UK practice was a milestone that made us think about how we manage the yearly flu influx, and from that, the idea of cohorting patients together, the idea of fit testing people and training people to use PPE has become more commonplace, and also the way of sort of yearly planning the work across the hospital, anticipating that there will be some degree of stoppage of elective surgery, elective services during flu season has sort of very much taken hold. In 2014, 2015, I was privileged to be part of a research team looking into new novel treatments for the Ebola virus during the outbreak in West Africa. So this was my first proper research job, and it was also my first proper experience with Ebola, and sort of quite a nasty pandemic. So Ebola, as you're probably aware, is a viral pathogen. Normally, you get isolated outbreaks within Western East Africa that normally sort of burn out quite quickly. But in 2014, 2015, it was spreading like wildfire, particularly across Guinea, Liberia, and Sierra Leone. So my experience here really reinforced and made me think about how we use PPE to protect staff. And I think that that's very much in the forefront of your mind when you recognise that the mortality rate from Ebola was up to 70%. So that was something that all healthcare workers were wanting to take serious for their own health. Not only was just the wearing of good quality PPE, but it was actually thinking about the infrastructure that surrounds putting PPE on. So having properly demarcated areas of where the high risk areas were, where the intermediate risk areas were, and where the low risk areas were, and having really good discipline about putting the PPE on, the donning of PPE. So buddy checks, making sure that you've got all the articles on properly. Your conduct while you're in the high risk area, and then actually sort of a very structured, well policed process of taking the PPE off afterwards. And during that outbreak, the centres I was working in saw no transmission from patients to staff because of that very disciplined approach to PPE. One of the other one of the other things that struck me was in a pandemic, when you're dealing with a novel infectious agent, actually we have a baseline understanding of how to deal with new infectious diseases, but actually there's a massive amount of research that needs to rapidly go on alongside the clinical response and the upscaling of that clinical response in order for us to better understand that pathology, understand how it spreads, and then start to understand how that spread can be stopped and how people who become infected can be treated. And finally, I think this is the aspect that really speaks into our talk, is an understanding of the patient pathway through a treatment centre. So most of us in our clinical work are used to dealing with what we call an unselected take. So that is, any type of patient can show up and need critical care. They might be a surgical patient, they might be a medical patient, it could be DKA, it could be a community acquired pneumonia, it could be an exacerbation of asthma, it could be another infectious disease. So you get quite a broad spectrum of presentations happening during peacetime. During a pandemic, what starts to happen is the variability of presentation is very much reduced, and actually the majority of people are presenting with the same sets of symptoms and the same clinical requirements, and that very much fits into having a very organized patient pathway or patient flow through the health system. So with Ebola, it was a very sort of linear flow for patients. They came, they were triaged. If at triaged it was confirmed that they were a suspect, they went into the suspect waiting area where they were tested. Depending on the results of the test, they were either discharged home or confirmed and stayed within the treatment centre. Once they'd cleared the virus, if they survived, they then went to convalescence, and when we were able to prove that they'd stopped shedding the virus, they were discharged. So that was what was happening in the Ebola treatment centres, and it was a very linear process. And I suppose for me, having seen this very linear response to an infectious epidemic really gave me the mindset that what we needed in our local response to the COVID-19 challenge was a very clear forward-thinking pathway, which would take patients at the beginning and follow them through. So just starting to think about the challenges that COVID-19 presented, there were lots of media reports, there were lots of anxiety coming out around the beginning of the year. It was a new disease. The pictures that were coming across on the media from China looked awful. There were pictures of people receiving healthcare in corridors, outside hospitals, field hospitals being set up. And the early data was suggesting that this was a pathogen that was hitting high numbers of patients, and it was spreading through communities very, very quickly. That said, the presentation, and this is going back to the idea of having a very similar presentation, the presentation of the patients was largely similar. As the reports became a little bit more structured, it was clear to us locally that we were going to need to increase our ventilated bed capacity by a factor of between 5 to 10. So providing 5 to 10 times as much ventilation capacity as we normally could. We were expecting staff to become sick. We were expecting to need to stop our elective services and probably much of what the hospital normally does in order to deliver a response to the COVID-19 pandemic. We were expecting, as we stopped those services, to have to recruit people from other areas of the hospital to come and work in ICU. So we're going to be having non-ICU trained staff working with us. The ICU staff that we did have, we're going to have to work in very different ways. So at our hospital, we tend to have one nurse looking after one ICU patient. And it was very clear to me from the outset that if we were going to have to increase our capacity by tenfold, those nurses who were experienced looking after one patient were going to have to supervise other members of staff who were looking after patients, and possibly themselves not actually look after a patient, but take on a more supervisory role. We actually have quite a lot of ventilators at our trust, so that was less of a concern because we were able to use anaesthetic machines. But there were lots of ancillary critical care devices that we were going to be limited with. Hemofilters, particularly, we were expecting 20 to 30% of patients to develop renal failure, syringe drivers, ICU beds, etc., etc. Having worked with Ebola, one of the really challenging things was that the situation is constantly changing. Patient numbers are changing, protocols are changing. The message from central government is changing all the time. So we knew that we were going to be dealing with a rapidly changing situation on the ground, and also rapidly changing advice from central government. Normally, our supply lines in the UK are pretty well protected, and well, there's a bit of a lag time on requests. Normally, we get the supplies that we want. And it became very, very clear as we were trying to scale up our ICU from a relatively modest number of beds up to a massive size, that everyone else around the country was doing exactly the same things. And that was putting immense strain on supply lines, so that even though we could work out what extra equipment we needed, both in terms of hardware, but also in terms of disposable and drugs, everybody else in the country was doing the same sort of thing. So that was going to be a real challenge that we were going to have to think about how we dealt with that. And then the other thing that became clear was there were lots of people who were, in very well-meaning ways, coming up with lots of different ideas about how we should be managing the situation. But quite often those ideas were not the most practical ideas, and actually often worked as a distractor from the main thrust of what we were hoping to achieve. So in my mind, there's a bit of a paradigm that you need to get your head around. Well, we have a new virus that's coming to us that we don't know all that much about. In many ways, the information we had around February, to me, suggested that it was a new pathogen, but actually it behaved, or it caused the sort of ICU syndromes that we had well-established ways of managing. So essentially it was causing an ARDS-like picture. And on our unit, we've got a very good lung protective ventilation strategy that's well adhered to, well audited, and everyone's on board with that. We've got quite a good process for proning patients. We've got good fluid management of patients. We're quite good at putting tracheostomies and weaning patients. So in my mind, actually, while this was a new pathogen, it was merely presenting to us, clinically at least, challenges that we had well-established pathways for managing those problems. This just again to make the point, one of the other challenges was we were going to have to move from sort of this idea of having lots of different types of patients presenting to us to just having sort of one type of patient presented to us. just spending a little bit of time on these, on sort of impractical ideas that were coming up. So around February time, you may have seen some of these videos. There were ideas about ways of reducing aerosol generation during intubation by putting plastic sheets over patients or building perspex boxes. In view of the fact that there was going to be limitation on the number of ventilators available, there were videos coming out demonstrating how you could ventilate 4 or 5 patients using the same ventilator. And a lot of people were getting quite excited about these ideas. And I took quite a strong line at the time, saying that what we were going to try and focus on is doing what we do well, as opposed to embracing new and untested ideas, which I felt were probably going to be distractors from the main thrust of what we were hoping to do. These pictures are from an article with a reference just down there at the bottom. It's just been published in Anaesthesia the last few weeks. So what were some of the existing strengths that we had on our unit? The way that we're set up, we actually have quite frequent rotation of junior medical staff and medical students. Some of the people who rotate through our unit are within the first few months of qualification. So they are quite junior, but what we do find is that we've got a good system for bringing people who have very little understanding of how to work in a critical care environment, and quite rapidly we get them working at a level, you know, sort of within a week or two of being on the unit, where they're actually doing things that are really useful to patient care and for patient care. We've got good working relationships with many other departments across the hospital, particularly theatre and departments of surgery. As I've already mentioned, we've got good pathways for managing ARDS and for managing the weaning of patients. And I think we've got good team working as well between medical and nursing staff. So suppose in terms of thinking about how we were going to set the standards of what we wanted to achieve during this pandemic response, we had to think about the challenges that we had and those pre-existing strengths, and try and come up with a way of working that was hopefully going to enable us to meet the challenge of providing between 5 and 10 times the number of ventilated beds that we needed to do. So I'm going to expand on these points but later on in the presentation, but this is just briefly to say the sort of things that we did. We had a phased response, so we recognized that in a pandemic, you start off getting 1 or 2 patients, and then 2 or 3 patients, and then 4 or 5 patients, or 7 or 8, or tens of patients. So we knew that we couldn't just move from normal way of operating to crisis mode completely, but we needed a bit more of a phased response, so different movement across that. I was convinced that we needed to really have good training for the use of PPE in donning and doffing, but not just the training, but also having real structure for where those donning areas were, where those doffing areas were, and actually having extra staff in the donning and doffing areas to help and assist and police that process. We used a lot of simulation, and the simulation was 2 ways really. First of all, we wanted to use the simulation to understand what the challenges were going to be, of doing things in PPE, but we also wanted to use the simulation for training ourselves on how to respond to things. We developed a standard management plan, which was largely based on the current processes that I've already alluded to. And then we started to recruit doctors, largely surgeons and paediatricians, to come and help us. And we sort of base that on a small set of core competencies, very clear in what the expectations were going to be for those doctors, and sort of very clear, well, they may be a consultant urologist in peacetime. Actually, we were going to want them to work at a very junior sort of year 1, year 2 ICU trainee level when they came. Within our way of operating, we met with the daily referral teams to discuss admissions and just to have a point to touch base about how both sides were getting on. Recognizing that we were going to have supply limitations, we also tried to build in some flexibility as well and plan for what our plan B, plan C approach would be should we run out of our usual drugs and usual equipment. We wanted to use handover, recognizing that not only would we need to hand the patients over, but because we were working in a rapidly changing environment, we wanted the handover process to be used also to hand over more strategic information as well. But we also wanted to use that to support people pastorally, recognizing that this was going to be a really stressful time for the workforce, and also to consider how things were going as well. And then we recognized that we were going to have quite a lot of staff who were relatively unskilled in ICU. So as opposed to training them how to do the whole of ICU at once, we recognized that we could probably teach them to do part tasks. So we developed a proning team to help with proning patients, an intubation team to go and intubate patients and retrieve them and stabilize them, hygiene teams, communication teams, just so that we could manage the workforce a little bit more. So in terms of the phased response, we had our usual ICU footprint, and we knew that we would sort of start with our first patient in the side room and then sort of progress through the ICU area and the HDU, and then we would spill out into various areas of theatre. And alongside that escalation process in terms of the space that we were occupying and the number of patients we had, we also had an understanding of how we were going to reduce the level of care that we were delivering, and we were on a daily basis reviewing the staffing levels that we had to man those areas. So this is just a quick picture. This is a recovery area in one of the theatre blocks that we converted from a small 8-bedded recovery area into an 8-bedded ICU area. And then the picture on the right-hand side is one of our theatres, which we changed from a operating theatre into actually a 4-bedded intensive care. And that was going to partner up with other theatres in the same block and produce a larger ICU area. And as you can see by the bedside, as opposed to the traditional ICU ventilators, we've got anaesthetic machines, because by the time that we were escalating to these areas, we would have run out of intensive care ventilators and be using anaesthetic machines to look after the patients. PPE training, as I've said multiple times already, was really important. There were some training videos that were put out by the by Public Health England, so the body that's in the UK that's been largely responsible for coming up with the infection prevention measures in the UK. We had all our staff look over those videos, but then we talked through the system that we were going to have locally to assist with donning and doffing, and then we did simulation wearing full PPE in order to get people not just trained in terms of how to put the PPE on and off, but also start to think about the challenges of working in full PPE. Just thinking about the system that we had, what we tried to do across all of our escalation areas is think about a one-way system that would enable us to have that donning and doffing process working as optimally as possible. So we wanted an entrance that you went into when you were clean, after you'd just donned, and then a doffing area where there would be a safe area to slowly take off the various elements of PPE, wash the reusable aspects, and then come out of that clean. And we sort of produced a set of ideas about what that process was going to be, so that we had a standardized way of doing things. And then we had some of the less skilled staff actually in the corridor, assisting with donning and assisting with doffing, so that we had a really really structured way and policed way of adhering to that standard. So simulation, in our hospital, our anaesthesia department's divided into two, really. We have the intensive care side of the department that looks after intensive care and provides a bit of anaesthesia, and then we have the general anaesthesia department that that predominantly deliver anaesthesia and look after maternity services. So what we tried to do is have an intubation team that would go and retrieve the patients, intubate the patients, and bring them up to ICU. And that was predominantly led by the general anaesthetist. And here's a picture of them, not wearing the full PPE that they would normally do because it was a training situation, but wearing some of the PPE and just working through how they would safely intubate patients. This is the standard management plan that we developed, and it was largely based on our lung protective ventilation strategy. So it described wearing PPE, described what lines we would need for patients, described the sedation protocol that we were going to be using, the cardiovascular targets that we were going to be looking to achieve, the feeding regime, and then putting a lot of focus on how we would deliver that lung protective ventilation. A little bit further down, it's not on the screen, but we also wanted to think about every patient that came into the unit and ask whether they were eligible to be randomized to any of the trials that were going on for critical care treatments in COVID patients. Just thinking about the recruitment, education and induction. So we developed this very simple document just to have a set of standards that we wanted all the doctors working on the unit to have done. So this was ensuring that they had appropriate access to the various IT systems that we use, so that they could look at blood results, they could look at imaging, they could access the electronic prescribing. They needed to be fit tested for the correct face mask as part of PPE, watching the PPE video, and then doing a various just short updates and simulations for various aspects of patient care. And this was both to provide some assurances to people working on the unit that they had some training, but both for us, also for ourselves, so that we knew that we were not only just setting the standards that we wanted to achieve on our unit, but that we were seeing that people were aware of those standards, and we delivered some education to support that. So for the surgeons, this is myself with a group of quite senior general surgeons, orthopedic surgeons and urology surgeons, all of whom came to help us when we were at the peak of our wave. This was probably two weeks before we received our first patient. And to the surgeons, what I was saying is, you know, you're very skilled clinicians, but a lot of the skills that you have are not going to be particularly useful for this patient set, or it may not seem like they're useful. So in the first instance, what we were asking them to do was to work at the level of a first or second year trainee doctor. And we talked about what those responsibilities were, and that was quite useful for them because they were all keen to help. They all knew that they were probably not going to be able to do any of the operating that they're used to doing, but they were also quite anxious in terms of what it was that they could do. So actually setting a standard of what level you were expecting them to work at was very useful for them initially. Actually, what we then found is, because they're all senior decision makers, they all worked at a very high level and were able to give a lot more useful suggestions in terms of management of patients than perhaps a first or second year trainee might do. As a critical care consultant body, what we tried to do is we tried to develop a hierarchy where all the jobs that could be done by other people who weren't ICU consultants happened with non-ICU consultants, and we tried to be there to make some of the difficult decisions that needed to be made and to coordinate activity. And one of the roles of the ICU consultant body was to go and sit down and chat with the referring teams, so people in the emergency department and people in the acute medical department. The purposes of these meetings were, firstly, I guess, kind of pastoral, just touching base with each other and understanding how many patients each of us were dealing with, but more specifically, discussing some of the difficult cases that we were facing. And I suppose one of the things that became useful in these discussions were the national reports from our intensive care audit department nationally, which was looking at all the patients who were being admitted to critical care and looking at what the actual risk factors were for mortality or survival, and this data became increasingly useful as we recognised that the very elderly, the very frail, and those requiring significant help with daily activities were the ones that were faring quite poorly in critical care, and that was useful data to bring to those meetings and to chat over as we discuss various potential admissions to the unit. So as I mentioned, we were expecting supply lines to stop working, as we knew that every hospital across the whole country was going through a similar situation as to we were. So we tried to not only just have a standard way of working from the outset, but also think about, if we didn't have those drugs or that equipment, how could we achieve a similar thing in an organised way using a different set of drugs? So our usual sedation regime on our unit is remifentanil and propofol, but we recognise that propofol and remifentanil may run out quite quickly. So we developed a sedation protocol for alternative drugs should remi and propofol become difficult to get a hold of. And some of them were using, sort of quite standard alternatives, fentanyl, alfentanil, but we were also thinking about, should things become really difficult and we not be able to get hold of any strong, fast-acting IV opiates, thinking about giving things like modified release morphine down NG tubes. So that just gave us a fallback that we knew was there should our usual way of working stop. Some of the challenges that we came across. So initially we were aiming to keep patients quite dry based on the experience and the advice from China. What we recognized quite early on with the first few patients that were coming through was we were probably drying them out a little bit too much and running them too negative. So we, on the basis of that recognition, we changed our standards to try and keep patients more euvolemic as opposed to aiming for a negative fluid balance as we had been doing. Another challenge that came up quite early on was we were finding, particularly with our nursing staff, because they were on the unit for 3-4 hours at a time, they were developing pressure ulcers on the bridge of their nose and on their cheeks from wearing the tight-fitting PPE masks. So we were able to recognise that quite early on, start thinking about rotating staff more frequently, and looking at alternative ways as well. So some of the staff who seem to be prone to pressure ulcers now use hoods as opposed to just face masks. For handover, as I said, we recognised we were going to be in a rapidly changing environment. We knew that we were going to have lots of patients that we needed to hand over. We knew that the staff were going to be under immense amount of strain from the work that we were asking them to do. And we just wanted to have the handover as a way of not only getting over the usual clinical information in terms of, we've got 20 patients, 30 patients, and these are the various details of them, but just doing a little bit more. So at the end of each handover, we checked how people were doing. Did they have any symptoms of COVID, and did they need to be sent home and tested? Were there any updates? So as we alluded to, and as was alluded to in the introduction, things change very, very rapidly. So were there any updates that we needed to discuss as a group? Were there any safety issues, any urgent things that we needed to do? And then just thinking about looking after our workforce, identifying physical and emotional fatigue amongst people. And while we were working in quite a difficult situation, trying to raise our spirits by recognizing what it was that we were doing well, what was the excellent work that was going on well, and recognizing that early and articulating that. So the results, this shows the admissions to our hospital. The orange lines are all hospital admission, the blue parts of the line is the number of critical care admissions, and the green line is a rolling 7-day average. So as you can see, we had a relatively slow build up to a peak around the start of April. And then following that, we've had a slow tail off to the point now where we see one patient every few days on the unit. We're now at a point where we're questioning whether we're going to see a second wave or not. Comparing ourselves during the first wave with the national aggregate data, the patients we admitted were ever so slightly younger than other units, but probably not clinically significant. As is the nature of our particular catchment area, the majority of our patients were predominantly Caucasian, and that's just because we live in a relatively non-ethnic minority area. Our patients were slightly more affluent, and again, that's representative of our catchment area. We had a much higher BMI, so our patients were much larger than was seen on other units, which is difficult to explain. In general, we tended to admit more independent patients, so other units were admitting about 10% of their patients who needed some assistance with daily activities, and we were tending to see fewer admit patients with fewer comorbidities. We tended to intervene earlier with our patients, and our results were we saw on average a above average survival rate compared to other units. So we were quite pleased with that result. And I think that that is testament to the hard work that the team have done, both preparing and then delivering the care that over the last 3 months. So just coming to the end of the presentation now. On reflection, I think we did a reasonable job of anticipating where we were going to be challenged and where we were going to see problems. And we were also quite good at understanding where our strengths laid. And we were able to come up with a plan that tried to use those strengths to manage the challenges that we were gonna see. We saw a higher survival rate. Actually, the number of staff that fell ill with COVID-19 was extremely low, and that was bore out with we've done COVID-19 antibody testing in all our staff, and that's quite a low rate of positivity. And we were able to deliver a safe 5-fold increase in capacity. So for us, our first peak required us ultimately to increase our workload by 5-fold. What does the future hold for us? I think a lot of our staff are quite emotionally scarred and worn out from the experience of the last 3 or 4 months. And we're currently doing a lot of work trying to support them as we look to the future. During the last 3 or 4 months, there's been a lot of operations that should have happened and haven't happened. Particularly cancer operations are worrying. So that's a picture of one of our urology surgeons with the robot that we have, and we've been trying to get the regular cancer surgeries upgoing, because those are the most pressing surgeries that we need to go on for. And as we're looking to the future, we're very much conscious that we're probably going to see another peak in COVID-19 infections. At the moment in the UK, the predictions are that that's going to be during October, November time, but it is very much an unknown if and when that will come. And so we're trying to consolidate a lot of the learning and experience that we've had over the last 3 or 4 months in terms of how we will respond when we're requested to do that again. Just want to thank you for signing up and listening. I want to thank the team and all the guys that I've worked with for working and providing really great patient care. There are too many names to mention, but very appreciative of that, and I'm happy to take questions.
Thank you very much, Dr. Matthew Jackson. That was indeed a very lucid rendition of such a key healthcare challenge in today's environment. Indeed, this crisis has pushed both the patients and the clinicians into uncharted territory. And you have very well decrypted the procedural nightmares that we are all facing in today's hospital environment. And your extrapolation of your experience in the Ebola and swine flu has definitely helped your hospital deal with such a bad pandemic. Thank you for setting the protocols and flowcharts for patient management and how to optimize the resources that we have, which is depleting by the day and by the hour. It's definitely heartening to see that you are in your hospital and across the UK that the cases are tapering off, and hopefully now that in India with our resource poor settings in place, we hope to taper off soon as well. But we are yet to see the peak. I would like to start off the questions with one of the questions was, how do you handle the post-traumatic stress disorders that are of the healthcare workers? And is there a standard SOP in your hospital to deal with this, and we have seen a number of videos on social media of the healthcare workers breaking down once they are relieved of their duties and go home. So how do you deal with it?
Yeah, it's difficult. I think there are two responses I'd like to give. The first is a personal response, and the second is sort of more of how we behave as a system. It's a stressful setting and situation that we're all going through, and I think it's easy to be, when we're stressed, it's easy to sometimes get a little bit angrier or speak in slightly more coarse or unpleasant terms than we would normally do. So I think just on a personal level, it's important to try and interact with colleagues in as nice a way as possible, and you know, sort of just support. Try and engage in sort of coffee room chats, and just acknowledging that we are all under stress and all struggling. So that's kind of on a personal level, and that is a real challenge. On a more institutional level, we've been discussing with our psychology and psychiatry department how to support people, and their advice has been, actually, if you do too much too early, you can actually cause more damage to people psychologically than actually just leaving it a little bit. So the advice has been just to try and host listening events and debrief sessions where people can just talk openly if they'd like to talk, but not putting too much structure there and too much pressure, because their advice to us has been that, you know, if you're putting lots of structure and pressure on people, you must debrief, you must reflect. Actually, that can further traumatize people, and often what they need is a little bit of time to process things. I suppose on the other thing on an individual level is, yes, there are lots of negatives that we're going through, and there are lots of negatives that you're seeing, but trying to dwell on the positives that are there as well. You know, this is for us as healthcare workers, I believe, a real opportunity and privilege and honour to be able to serve our communities during this time. Indeed.
I just want to take this opportunities with Madhusudan also present to pick your brains on certain clinical strategies. You mentioned one of them was the strategy to have a volume restriction versus euvolumic state.
Yes.
I was reading an article that has come out recently where they're iatrogenically push the patient into almost acute kidney injury to treat the ARDS, because you know, the past experience, we are all extrapolating our experiences with previous ARDS protocols and trying to dehydrate the patient in the hope that the lung recruitment will be much better. What is your opinion about this? In fact, you have told us, but can you elaborate a bit more?
So my reading of the evidence is certainly liberal fluid strategies are bad for ARDS, and we need to be aiming for more euvolemic strategies. I think our critical care unit, if I'm perfectly honest, is slightly more liberal with fluid than I'd like us to be in usual times, and we'd seen a lot of the advice, particularly coming out of China and Italy before we hit our peak, suggesting to really run patients dry. And what we were seeing and what we were hearing from other hospitals was very much the article that you've referred to, in that, you know, patients were being pushed into iatrogenic renal failure. So I think what we've tried to do is we've tried to aim for euvolemia. We've used diuretics, so we use furosemide and spironolactone to try and maintain euvolemia, but not aiming for a negative balance. And if patients need fluid resuscitation, we've had a much lower threshold to use albumin as opposed to just crystalloid to deliver those fluid challenges. Our incidence of renal failure, I think, was between 5 and 10%. It was actually quite low, much lower than the data that was coming out of China and Italy, which was suggesting that the incidence of renal failure would be between 20 to 30%. So I think euvolemia is the key here. Certainly not a fluid liberal strategy, and probably a negative balance. Well, you may save the lungs. You will ultimately stop the kidneys from working, and then you know, particularly if you don't have hemofiltration, then that's causing further problems for patients. You know, and that was one of our concerns. Well, we had hemofilters, actually getting the disposable materials to run renal replacement therapy was becoming increasingly difficult to get in the UK, because we're largely dependent on Italian suppliers. Okay,
one question to Dr. Madhusudan. We are all aware of the happy hypoxia that is taking place in these patients, and most of the patients are asymptomatic until they hit about less than 80 peripheral oxygen saturations. And what, in your opinion, is better lung recruitment strategies in your institutions?
If you talk about our institutions, I think we haven't treated many patients unless they have comorbidities. But I think the evidence is obviously happy hypoxia is to be practiced. And then awake proning is something which is, I think, has been advocated. Even ICMR guidelines also talk about awake proning. I think does UK practice awake proning in early stages of ERDS before they are paralyzed or before they are sedated deeply? I think
yes. So we have been doing awake proning in patients. Our experience has been it certainly improves the oxygen saturations on the patients, improves the numbers. I'm not personally convinced it actually improves the clinical course per se, but we have been doing that.
I think by the time the awake proning came up, you had started the plateauing the line.
Yeah.
But our line is still on the ascent. Therefore, we are practicing the awake proning in India. I think it's showing good results, and that's why it found its way into the guidelines.
On the use of HFNC or NIV marks is much better than putting the patients, intubating the patients. What is your threshold for intubation, Dr. Matthew?
So we were tending to intubate patients. We didn't use a massive amount of non-invasive ventilation. We didn't use much high flow oxygen. So we were, when patients were on 15 meters on a non-rebreathe mask, and they were unable to maintain the saturations above 90% for prolonged periods of time, that was our trigger to intubation for most patients. I think looking at our experience and looking at the evidence that's coming out now, we would probably try non-invasive strategies and high flow oxygen a little bit more in selected patient groups.
Yeah, high flow nasal
there's
oxygen.
A question.
Yeah. And
Go
NIVs,
ahead,
but either of it, when it is practiced, I think we should be on the guard. And if the patient does not pick up, or if the patient deteriorates, we should be able to tube them and ventilate them early. Yeah. We cannot be wasting too much of time on NIV and high flow nasal oxygen.
Yeah. And certainly our experience was the few patients that we did have on high flow and NIV, we probably managed an extra 24, 36 hours, but when they came to needing intubation, they really did crash on intubation. So I think we would try it in selected patients, but I would still personally advocate earlier intubation with these patients.
Yeah.
one question that we have got is the concern about the from the healthcare workers side is because there are in Bangalore, or at least from where there are very few ICU beds available even for the healthcare workers who turn positive or who deteriorate during the situation. So did your hospital have any designated beds specific to the healthcare workers if they turn positive and deteriorated?
No, that's not something that we would have done. We just unfortunately we'd assess each patient on their own clinical merits, regardless of whether they're a healthcare worker or not.
Dr. Upadhyay, are you facing similar concerns from your fellow doctors and nurses?
Yeah, it's actually, I didn't say this, but quite a few healthcare workers are contracting the disease right now. And we already have crunch for beds. Therefore, arranging a bed for a healthcare worker obviously should be a priority when I am working in that institution. But we find it a little tougher to displace a patient who needs and then try to get in a healthcare worker onto that bed. It's a little tough, but I think we have to find a way out. I know that there is a government of Karnataka circular which says we have to identify some beds for the healthcare workers, and I think it's time, because maybe I'm talking about purely Indian perspective. Matt, pardon me.
Mm-hmm.
When we contract the infection, when we cater to the COVID patients, I think we deserve a little bit of reservation there. That's why. Yeah.
Dr. Matthew, what hemodynamic monitoring were you using? Was it a bedside echo, or you had other modules to help you with the hemodynamic monitoring?
So we predominantly use arterial lines. The patients have CVP monitors in, but we don't look at the CVP values particularly to think about hemodynamic monitoring, and largely bedside echo. So just very basic echoes, looking at how full the ventricle is, how well the ventricle's contracting, and we did start to feel that lung ultrasound was quite useful in working out the phenotype of lung injury that the patients had.
Okay. What percentage of your patients were on ECMO eventually?
So we actually didn't refer any patients to. We referred 1 or 2 patients to ECMO when they were at a point where we were starting to struggle with oxygenation, but actually none of the patients ended up needing ECMO.
How is the availability of remdesivir and tocilizumab and the dexamethasone in your hospitals? Is it freely available?
So dexamethasone and remdesivir were available as part of clinical research in our hospital when we were at peak. Within the last month, the UK have made those 2 drugs freely available to patients who meet the various criteria for each of those. So those 2 drugs are available. The other combination, we don't have that available.
Dr. Upadhyay, are you starting your patients on dexamethasone straight away? Now,
no, early
recent studies are saying that the earlier you start, the better with that.
Even the guidelines actually now start. They talk about early starting of dexamethasone in COVID ERDS. I think we do start, and even the remdesivir, whoever again, Matt, Indian perspective, whoever can afford has been receiving remdesivir.
Yeah.
Okay. What investigations do you think will help us guide the ICU patients? Like your IL-6, was it easily available? Investigations, were you doing D-dimers? What investigations were you banking yourself to take decisions?
So we actually just use a relatively basic set of investigations for the majority of patients. We were doing full blood count, renal function, liver function, C-reactive protein. Later on, so we don't normally have procalcitonin available to us, but we started using procalcitonin, and then in selected patients we were using D-dimers. I think for me the most useful investigations were actually how much oxygen the patient was requiring, and whether the patient's desaturated on basic nursing care. Those were the two key markers for me, really.
The clinical features, you mean?
Yeah.
Dr. Upadhyay, in our resource port settings, I was reading an article where they were doing serial CBCs counts and finding that lymphocyte count was a very good indicator of the patient deteriorating.
Yeah.
Do you think that will going forward in our setups where most of our clinicians may not have even heard of D-dimer or IL-6 investigations and all those things? So that could be a face saver, isn't it?
It might be a game changer too. Series of lymphocyte count. I think it should give us an indication where the patient is heading to. But IL-6, basically, see, even in a place like Mangalore, we have to send it to Manipal. It's 60 kilometers away, and the report I can get only the next morning. Therefore, IL-6, even if it is available, it takes time for the reports. That's why it becomes a little D-dimer. Obviously, we can do it on the spot. It should be available in a couple of hours, but still, this is the problem. Series of CBCs, I think, will be may not be a bad idea.
Yes. How many patients did you actually see the CRS syndrome, that is the cytokine release syndrome, Dr. Matthew?
So we probably saw it in about 5, let me just think, about 10 patients. So pretty much all of our patients that died had this cytokine release syndrome. The majority were just, it was ventilation that was the problem, and it was almost universally single organ failure. The cytokine storm we saw in the minority of patients, probably about 10 patients, and they were the patients that went on to do poorly.
Poor prognosis. Dr. Upadhyay, what would be your endpoint? What saturation levels would you be looking at? Either when you do any of these lung saturation, do you want to have more than 90-96%, or you are comfortable with around 90 to 96% saturation?
With a NIV or high flow nasal oxygen, if I can bring it up to 90 and above, I think we should be happy. And once the patient gets intubated and ventilated, I think we can look at 94 to 96% of PaO saturation with the FiO2 of maybe 0.6. We should be okay.
Okay. Do we have any more time for further questions, or do we?
There is time. And
we still have 5 to 6 minutes left, Doctor. So if you have any questions, yes, we can definitely proceed.
So,
Mahesh, can I just say something? So,
please.
In fact, one of my colleagues from South London, Dr. Nataraj, is also here. He's a concerned anesthetist in Surrey. He's also a deputy regional advisor there. He's also online. If you need to catch out of him, Matt, I think you might have met him in the university before.
Hi. Yeah. I don't know. It's a long time, Matt, since you worked there. I think we had quite a lot of problems with thrombosis. I mean, after about 3 to 4 weeks of this COVID patient's treatment, we thought that, well, we got to get on to the anticoagulant status much earlier than we thought. We were running dry, as you said, and that was probably running one of the lesson learned, to not to run them too dry, just leave them euvolemic, and then put them on anticoagulants, prophylaxis much earlier. That was really helpful. And another other thing comment was 80% at FiO2 of 0.8. We used to use a lot of CPAP. We used a lot of non-invasive ventilation, but later on we thought, well, we should have intubated earlier rather than leaving them for too long CPAP. We also had trouble in getting CPAP masks as well initially. That was another supply problem. Later on we managed, I think we intubate more patients earlier rather than leaving on CPAP, getting them tired. So that was another lesson learned.
What is your opinion, doctors, about
I have
the
to say,
convalescent plasma? Yeah, sorry.
I have to say, in the south, we did reasonably well. I'm in Guildford, southeast London, so reasonably well. The mortality was okay than actual central London. Yeah, sorry, you were saying something, Mahesh.
Yeah. Is convalescent plasma easily available in UK at the moment? Because that's the next big thing that is coming up everywhere. A lot of literature on use of plasma from patients who have recovered from COVID-19.
Yeah, to my knowledge, we didn't use on anyone. I don't know, Matthew, what you did there.
So convalescent plasma is available as part of a research protocol. That's the only place that I'm aware that it's available. So we've not actually given it, but we have the ability to give convalescent plasma if someone's randomized to active treatment on a particular trial.
Yeah, we are fortunate in India because actually we are down the ladder because we are now going into climbing the stairs to reach a peak, and so we have taken the good strategies from all over the world. So straight away we are starting them on dexamethasone, remdesivir, and some patients are also on the anti-rheumatic treatment. But the problem is with most of these studies that are coming out, these studies don't have any basis. They're not peer reviewed, so it's very difficult to take any of their recommendations on board. So what about HCQs as a prophylaxis? What is your opinion?
Sorry, which agent was that?
Hydroxychloroquine, HCQ. Dr. Upadhyay, what do you feel?
I don't know.
Have you taken one?
No, I bought them long ago, maybe in the month of May or April or March end, I think. But I haven't taken them because there's no evidence to say that it might be protective. And as a prophylaxis, I don't think, Matt, any clue about HCQs? That's why I haven't taken them.
From what I've read, it's not something that I'm interested in for either myself or my patients.
But there have been anecdotal evidences to say that HCQs have been protective. And
yeah.
But as medical guys, we should not go by anecdotal evidence. We should have solid evidence. And unfortunately, COVID is such a pandemic. We can't have RCTs. We can't have the strongest of evidences. Therefore, sometimes I wonder whether anecdotal evidence is also all right to go in and pop in some tablets, because the side effects are not much as long as your heart is okay, as long as your liver is okay. But I don't know. Mahesh, you have taken?
Yeah, see, I have a confession today because, see, I was exposed to, of course, I was wearing my N95s and I was wearing my shields, but I was exposed to a couple of patients. So I didn't have the nerve not to pass it on, but I somehow avoided MMR. MMR, they said, also will give you some amount of relief. So I chickened out of taking the MMR. So
Yeah,
I suppose so long as the anecdotal evidence don't come from President Trump, we'll be fine.
no, we are being absolutely apolitical, and we will not take. There were some places in India where actually they tried it on a huge number of patients. But as you people are aware, at least Nataraj and Shashi should be aware that we don't keep documents. It becomes only anecdotal, hearsay, and they claim that the results have been good. Therefore, I think, as Mahesh said, when it comes to when you are pushed against the wall, maybe you can try that. There's no issue, I think.
A lot of hospitals in Bangalore these days are pushing for home care for most of these, even mild to moderate, because of our population and because of the poor bed to patient ratio. We are pushing a lot of home care systems have been put in place in India at the moment. So going forward, I think most of the population, until they need ventilatory support, they will not be in the hospitals, because we are running short of beds. We already run short, and I'm dreading any peak that will come henceforth.
I think that's a nice move, Dr. Mahesh. The patient, asymptomatics or mildly symptomatic patients, are retained at home, and they also have an access to a pulse ox. And
Yes.
if the saturation dips, he is supposed to call up the facilities, and he is immediately shifted to the hospital. I think that will bring down a lot of strain on the system. I think it's quite a commendable recommendation. It's nice. Even in Mangalore, we have quite a few patients at home on domiciliary management. I think it's good.
Yeah. So with this, gentlemen, I thank you for.
Just thought of
please,
comment.
please go ahead.
No. We were one of the center recruited for all these drug trials. One of the drug was hydroxychloroquine as well, along with other antivirals. A few drugs are in trials. Still, it has not come out the outcome of those trials yet. So I'm not sure the final outcome. What's it going to be? Yeah.
Do you have any experience with tocilizumab? Because a lot of patients in India are straight away being put on these drugs, and they claim that there is very good recovery with these drugs. So,
but another thing to confess is, see, we know that 95% of the patients don't even go towards the ICU, and the mortality is only 3%. Therefore, off the record, Mahesh would have come to know about an Ayurveda physician who claims to have treated patients in Victoria COVID hospital and claims success. Yes. I think the immunity boosters, as he claims, obviously when he uses it on those 95% of the patients, obviously will be effective. I can drink a lot of boost and say I was saved. And it doesn't matter much. It should be a proper research done, which hasn't been happening. Hopefully, by the time the COVID ends, this pandemic ends, we will have some evidence.
At least I was laughing my way when all over the world they started making ventilators out of scrap. I said they were wasting their energy, isn't it? So just a billows on a patient, how can they synchronize their breathing? So we all knew that. Luckily, the research showed that ventilation was the last resort, and then now that thing has automatically died away. That we are more into now CPAP and BiPAP machines on high frequency nasal cannulas rather than emphasis on ventilators. Exactly. So by the time the pandemic leaves us, we'll have a storeroom full of ventilators.
No, or maybe a few lesser ones, because fewer ones, because there were people who used the same ventilator on 7-8 patients at a time. God knows how they got that brainwave to do it. I don't know. Anyway, Matt mentioned about that. I think we should never think about such silly things in life as clinicians. Shashi.
Shashi, with your permission, can we round up? Or
yes, please. So,
any more questions?
I think
No.
We have Mahesh, you managed to go through all the questions, haven't you? So I don't think there's anything else. I think it's time to wind up. Yeah, thank you. You could conclude, Mahesh.
Yeah, thank you, gentlemen, for spending your Sunday evening deciphering protocols for ICU management and hospital management of this pandemic. I hope things look up very soon, and and all the healthcare workers and the frontline workers will be safe, and we have very little morbidity and mortality going forward now that we have enough experience from people like Matthew, who has shared his views. Thank you, gentlemen. I will over to Shruti.
Thank you so much, doctors. That was a very, very informative and an interactive session we ever had. I would like to thank each and every one of you for taking your time out from the busy schedule and doing this for us. Thanks a lot. And people, remember, be safe, take care of yourself, and we hope to fight the COVID very soon. Right. Thank you so much. And stay tuned for more such informative webinars. Thank you.
Thank you.
Thank you.
Have a nice day.
Thank you very much.
Take care.
Thank you, everyone. Thanks, thanks, Matt. Thanks, Madhu, Mahesh, Shruti, and Prajwal, Natraj for joining in.
Yep.
Thank you, everyone. Thanks a lot.
Bye, Shashi. Bye, Mahesh.
Bye.
Bye, Matt. Bye-bye.